What I want to talk about today is a drug that's kind of one of the newer drugs, Selinexor, also called Expovio. And for those of you who like to know where these names come from, and we'll talk about the mechanism of action of how Selinexor works, it targets something on the cells of a little portal that's called XPO1. So that's where they get the name Expovio. So what is Selinexor? So Selinexor is a new class of drugs in myeloma, and we call them SINEs, selective inhibitors of nuclear export. So what does that mean? And essentially, one of the best cancer fighters that we know of is our own immune system. And our immune system identifies cells as being cancer and targets them for programmed cell death, something we call apoptosis. And the body recognizes the cell as cancerous, and it triggers a cascade that goes into the nucleus and tells this cascade of proteins to commit suicide. The difficulty is cancer cells have discovered a way around this, and they have mechanisms of survival. And the way they try to survive is they kick out part of that cascade through these little holes in the nucleus of the cancer cell that we call exportins, or XPO1. So when they kick out part of the cascade and the body tells the cell to die, the cascade's missing parts. It's like you have a puzzle that you need to complete and you're missing 3 of the pieces. If you don't have the pieces, you can't complete the puzzle. If you don't have all the parts of the cascade, the cell doesn't die. So what Selinexor does is it blocks these exportins, it blocks these holes. So it traps the cancer cell when it tries to kick the parts of the cascade out, it traps them inside the nucleus, so the cell has to undergo cell death. And it basically allows the cancer cells to die and prevents them from spreading. And it turns out this mechanism of resistance to our own body's cancer targeting activities is active in a lot of cancers. Selinexor was recently approved within the last month for diffuse large B-cell lymphoma. The drug is active across a variety of other tumors. It crosses what's called the blood-brain barrier, so it's active in things like brain cancer. It works in certain sarcomas and prostate cancer. So this mechanism of action is actually quite exciting for us. And the drug was approved for myeloma in July of last year. And it was approved by itself along with dexamethasone, a drug that probably many of you know very well for the good and the bad reasons of dexamethasone. And it's approved for people who've had quite a number of prior therapies. And we usually say it's approved for people who have triple class refractory. So refractory to a drug like an IMiD, so drugs like Revlimid, refractory to a class like Velcade, proteasome inhibitors, and refractory to a monoclonal antibody like Darzalex. So that's the first approval. But most recently, some data was presented from the Boston trial. And this is some information from the Boston trial. And Boston trial looked at comparing Velcade and dexamethasone versus Selinexor, Velcade and dexamethasone in people who've had at least one prior line of therapy. And a lot of people take Velcade and dexamethasone in the relapse setting, and they wanted to see if this was better. And this is a phase 3 trial, what we call a registration trial, meaning that this combination and this study is being put forth to the FDA to get this combination approved. So this was presented recently, and the top line data was positive. It's a positive study. So the company that makes Selinexor actually filed this with the FDA, and we're waiting anxiously for the FDA to approve this combination, hopefully before the end of the year. So here's just one slide from one of our colleagues from Greece, Thanos Dimopoulos, and this looks at the combination of Selinexor, Velcade, and Dex versus Velcade and Dex alone. And here the Selinexor, Velcade, Dex, the triplet combination is in yellow. And one of the interesting things we see here is that, all the way on the left, overall, people do better with the 3 drugs over the 2, which is what we've seen with a lot of studies across the last decade, that we try to use 3 drugs over 2 because it seems to work better. But we know that myeloma is a heterogeneous disease. One person's journey is very different from someone else's. And one of the things we really wanted to look at and that Thanos presented was what this looks like across different subgroups. So people who are older, people who have higher risk disease, people who have kidney problems, people who've had one prior therapy or another. And what we can see here on this one graph is, across the board, if you were older, you still benefited from the 3. If you had higher risk, there's actually a more profound impact of adding Selinexor. And one of the things that we saw here, and that's very different from the Boston trial, as opposed to the original approval, was how to dose the drug. So in the original approval, the drug was given as a pill, or a number of pills, twice a week. When you give the drug twice a week, it has a number of side effects, including things like asthenia. And the best way to describe asthenia is like you just can't get off the couch. It can cause nausea, vomiting, and weight loss. And what we found is that we needed, when we just gave it with steroids alone, we needed to give more of it to get the myeloma to respond. But when we combine it with other great drugs in myeloma like Velcade, we can actually back off the dose. And here in the Boston trial, we only gave it once a week at a bit of a lower dose. So here the drug was, Selinexor was given 100 milligrams once a week, along with Velcade and dexamethasone once a week. And the drug was far better tolerated. We also learned a lot better how to manage and prevent the side effects, because we know an ounce of prevention is really better than a pound of cure in many scenarios. So instead of waiting to get the side effects, we become more aggressive by giving the standard drugs we use for nausea, like Zofran, which many people may be familiar with. But we use a few others that you may be less familiar with. A drug called Varubi, which is also called Relepitant, which is a really powerful anti-nausea drug that many people, if you've gotten transplant, you got a variant of this drug prior to that. And a kind of out-of-the-box drug called Zyprexa, which is also called olanzapine, which is used for people with psychiatric disorders and even very intense psychiatric disorders, but it actually really has a great antiemetic or anti-nausea effect. So we can combine some of these drugs and really get people to tolerate it well. And combining all three drugs, we found that people were doing extremely well. And we're hopeful that before the end of the year, we can get this regimen approved so that people who progress in the early lines may have this option. And even though we have so many different lines and so many different drugs, the benefit of this drug early on is that many people get drugs like Revlimid as part of their therapy early on. But if you don't tolerate it or you progress on it, you may want to switch to a mechanism of action, basically giving your cancer cells a drug that they've never seen anything like it before. And this provides yet another option for us as we kind of peer out who needs what at each line of therapy. But the ultimate thing that we really like to do when we see new drugs is combine them with everything. And there's a great trial right now that's kind of a basket trial, that instead of just one option for therapy, there are many different options, and it's called the Stomp study, Selinexor and backbone treatments of multiple myeloma. And here, this is the general schema for this trial. And we see that we can combine Selinexor with a lot of the drugs you may already be familiar with, drugs like Revlimid, pomalidomide, Velcade, carfilzomib or Kyprolis, and daratumumab. And one of the things that you can see if you take a look closely is that the dosing of Selinexor actually changes depending upon which drug you mix it with, because you have to account for certain toxicities. So one of the things that Selinexor does is it affects your blood counts. So when we combine it with drugs like Revlimid or pomalidomide, we may only give 60 or 80 milligrams once a week, because Revlimid and pomalidomide can affect your blood counts, and you have to be careful about causing too much cytopenias or low counts. When we combine Selinexor with drugs like Kyprolis or Darzalex that have a lot less incidence of causing low blood counts, we can actually crank up the dose back up to 80 or 100 milligrams once a week. So the reason why this trial is so important is, again, that everyone's journey is unique. And some people we may want to give Revlimid because they don't tolerate Velcade, or we want to give Velcade because they don't tolerate Revlimid. And the benefit of this trial is that we actually get to better understand how to optimally combine Selinexor with every different drug so that we can custom tailor it to the individual patient. And at the end of the day, this is really what we mean by precision medicine, taking these drugs that really may work in many patients, but optimizing the strategy and the combinations for an individual. And again, in all of these trials, the drug was given once a week, which reduces the side effects. And if we're aggressive about preventing them with drugs like Zofran, dexamethasone, Varubi, and Zyprexa, we find that the drug is much better tolerated and can actually work quite well. And it actually turns out that the basis for this trial, the early data for Stomp, actually informed how the Boston trial was designed and run. And that's why we're really excited now with the recent filing with the FDA that we are likely to have yet another combination option available for myeloma patients before the end of the year.